Okay, we are at the top of the hour. Hello and welcome to Sight and Sound Bites. I'm Heather Cronus-Danick, Senior Director of Development for Individual Giving and Corporate Partnerships for the Eye and Ear Foundation. The Eye and Ear Foundation is the fundraising entity for the world-renowned departments of ophthalmology and otolaryngology at the University of Pittsburgh School of Medicine. Everything that we do is devoted to helping people see, hear, and live better. Before we start today's webinar, a few housekeeping tips. Microphones are turned off, as is chat. Please put your questions in the question and answer box. We will get those answered at the end. And if possible, please refrain from personal medical questions. So it is my great honor to launch today's webinar on inherited retinal conditions, current treatments, and future research. Today, we are led by Dr. José-Alain Sahel, Distinguished Professor and Chair, Department of Ophthalmology at the University of Pittsburgh School of Medicine. He is the Eye and Ear Foundation Endowed Chair. He is the Director of the UPMC Vision Institute. He is the Executive Vice President of UPMC Enterprises, and he is Chief of UPMC Health Technology Advancement Program. He has grown the Department of Ophthalmology and UPMC Eye Center exponentially since he arrived 9 years ago. He is a world-renowned retina specialist who has authored or co-authored over 700 peer-reviewed articles, and he has been involved in discoveries that have led to over 90 patents. So we're thrilled to have him with us today. We next have Boris Rosin, Dr. Boris Rosin, who is an MD, PhD. He is an assistant professor of ophthalmology at the University of Pittsburgh School of Medicine. His entire focus is inherited retinal diseases. He has a robust lab that is producing lots of fantastic research that you'll hear more about. And finally, we have Morgan Brzozowski. She has her master's in genetic counseling. She is with the Department of Ophthalmology and the University of Pittsburgh Physicians. We are thrilled to have all three of you here today. And Dr. Sahel, I'm going to have you lead off.
Thank you very much. So I'll just say a few words to open the presentation. I think Dr. Rosin and Morgan Brzozowski are going to present after. So we tried to update, actually, because this is not the first webinar we are giving on this topic. We are trying just to update you on recent progress, and we decided to focus on better understanding the evolution of the disease, better understanding the genetics behind and how the genetic counseling is performed. And I will end with presenting some of the ongoing research and what we believe is the most promising for the field, although we all know that it's still work in progress. So I'm going to hand over to my very close collaborators, Boris Rosin, who is leading also the clinic on retinal degeneration with me and seeing a lot of patients affected and working in the lab on developing new therapies. So Dr. Rosin.
Thank you, Dr. Sahel, for this kind introduction. So I wanted to start off with basically an introduction to inherited retinal disease. And in order to better understand these disorders, we need to understand that our vision is basically governed by certain cells within the retina that are called the photoreceptors, or cells that are able to perceive light. And we all have rod photoreceptors, where they're responsible for night vision. And we have three types of cone photoreceptors, red, green, and blue, that are responsible for day and very, very sharp vision. The distribution of these photoreceptors within the retina is very different, and the rod photoreceptors are basically distributed more in the periphery of the retina, whereas the cone photoreceptors that are responsible for sharp color vision are actually more prominent within the center of vision, and this is what gives us the sharp vision that we all enjoy when reading, writing, driving, or watching TV. The actual ability of the photoreceptors to sense light comes from these particular proteins called opsins, and the actual molecule that is responsible for light perception is a derivative of vitamin A. And what happens is that when this derivative of vitamin A is hit by light, hit by photons, it changes its configuration. And this change of configuration basically initiates a cascade that results in activation of the photoreceptor. And there are many different types of opsins, and they all are characterized by a characteristic wavelength of light. So they all perceive different components of light. And the opsins that are within the rod photoreceptors are called rod opsins, and the opsins that are within the cone photoreceptors are called cone opsins. And as we said, they all have a little bit of different characteristics as far as the wavelength of light that they are most sensitive to. So you can see the blue cones, the green cones, and the red cones, and the rod photoreceptors are somewhere in between. They see kind of like grayish, bluish kind of colors. And once the opsin seen here in the membrane of the photoreceptor is hit by light, it activates a series of processes within the cell. In the end, there is an opening of a channel, and there is a change of the membrane potential. And this is how the photoreceptors convert light into electricity, which is the language of the brain. The vitamin A then needs to be recycled, and this recycling is done by a layer of cells that is immediately under the photoreceptors. They're called the retinal pigment epithelium. It's a very interesting cycle of processes that leads to this recycling of vitamin A. As you can see in this chart, many of the components of this cycle can be damaged or mutated or impaired in genetic retinal disease, and you get different disorders once you get this type of damage to the protein that handles the recycling of vitamin A. So how do we diagnose these disorders? And Morgan is going to talk about genetic testing, and I'm of course not going to talk about that because she's the expert. But actually what we do, we actually test the function of the retina. And the function of the retina is, as we discussed, is translating the image that we see into the language of the brain, which is light. And most of the work that we use today was done actually many, many years ago by this gentleman right here, which was a British scientist by the name of Garnered, who in 1936, that kind of like should make you understand how old this technology is, but it's still used very much today, received the Nobel Prize for this. And what we do is called electroretinography. Well, we're using very fine recording electrodes. We record the electrical activity of the retina in response to stimulation by light. And by using this, we can actually discern between the rod photoreceptors and the cone photoreceptors. As we said, the rod photoreceptors are responsible for night vision, so we can dark adapt the person. So all of the rods are available for activation. We can use very dim flashes, so we activate only rods and not the cones that need more light to be activated. And we can also use light, which is very close to the characteristic light of the rod photoreceptors, which is, as we discussed, is a little bit like grayish bluish. On the other hand, if we want to activate the cone photoreceptors, we will use light adaptation. So we will kind of like use a very bright light, and we also will use white light, which includes all the wavelength and will activate all the cone photoreceptors. So let's give a few examples of typical things that we see in our clinic. And I will kind of like say typical with quotation marks, and I will explain why in a minute. So this is a case presentation of a 36-year-old male who is generally healthy, and he's complaining of decreased visual acuity, which is progressive, and only partially improving glasses. He also complains about stumbling, difficulty going down the stairs. He has a severe disability at night, especially when it's really dark environment, for instance, going camping. And he has two brothers with a very similar problem. So on examination, visual acuity is indeed reduced. There is nothing in the front of the eye, and the back of the eye has very severe changes. And genetic testing, as always, gives us the answer. So the disease that we're talking about is called retinitis pigmentosa. And retinitis pigmentosa is really the leading cause of inherited blindness. Now, retinitis pigmentosa is really not a single disease. It's an umbrella term for many disorders that look very much alike. Its incidence is about 1 in 5,000 live births. But if you count things that include other conditions, let's say, as we know, vision and hearing are very intimately connected in embryological development. So if you have vision and hearing loss due to RP, it's called Usher syndrome. So when you include those types, it's more common. Now, when I said that we're talking about a typical case in our clinic, you need to understand, and this is something that our patients are often confused about, is that these diseases are exceedingly rare. And when you come and see Dr. Sahel or myself in the clinic, and you see other people with these conditions, you might think differently, but it's not the case. If I was to walk out onto the street and pick out a random person and ask myself, what are the chances of this person having any inherited retinal condition? The answer is 1 in every 3,000 to 1 is in 3,500, more or less. And certainly every specific mutation is much less common. So this is a picture of a normal retina, and you can see here the optic disc and the blood vessels of the retina emanating from it. And this is the macula, the center of our vision, the place where I said we have a lot of cone photoreceptors. And this is what gives us the sharp vision that we have. And this is just another type of the same image that we can take that gives us a lot of information. This is a completely normal image. When we look at the same picture of a person that has retinitis pigmentosa, we're impressed by 3 things. So first of all, when we look at the optic nerve, you see that the optic nerve is a little bit pale as compared to the previous one. The blood vessels look a little bit thinned out, as we say, attenuated. And there is a lot of pigmentation in a certain pattern. And these are the 3 cardinal signs of retinitis pigmentosa. And when you look at the other picture that I just mentioned, which is called the fundus autofluorescent photo, you see that it's actually also very highly attenuated. So as these people age, and this is a retinal scan that shows us the layers of the retina, you see that progressively from the age of 12 to the age of 62, there is thinning out of the retina and loss of photoreceptors and loss of vision. That is also manifested in electrophysiology. On the right side, you can see a control subject, which has a normal rod response, a normal combined response, and a normal flickering response, which is a measurement of the cone photoreceptor function. And all of these are badly attenuated to basically non-existent in our patient. We can also look at visual fields, and that is basically the field of vision where the person sees what's going on. And you can see that this field becomes progressively attenuated while the disease is continuing. And this is retinitis pigmentosa. And as we discussed, there are many, many different genetic disorders that cause this kind of like end-stage appearance of the disease called retinitis pigmentosa. I'm going to present another case, but I want to kind of emphasize that I brought 2 examples, which I felt that are very, very interesting. But as a matter of fact, there are hundreds of different disorders. They're very difficult to diagnose, and we are faced with a diagnostic challenge every day. But although this family of disorders is actually very rare, the variability of these disorders is I would not say infinite, but it's very, very complex. So this is a story of a 27-year-old male college student that at the age of 9 months, the parents noticed that he was squinting at the sun and he was severely photophobic. And somebody looked at his eyes and told him that he has a retinal degeneration. So he's very sensitive to light, doesn't have good visual acuity, doesn't discern color well, and he has nystagmus or involuntary eye movements since the childhood. He's usually healthy and has no systemic conditions. So on examination, his visual acuity is indeed very much reduced. His retinal exam looks more or less normal, but his retinal scan is not completely abnormal, as we saw for the patient with retinitis pigmentosa, but we see this cavity right here in the retinal scan, which is not normal. And this disease that I'm talking about is a disease called achromatopsia. So achromatopsia is a very rare condition, and this is kind of like an example of what we can encounter in the clinic, which is quite unique. And it happens in 1 in every 30,000 to 40,000 people. And it's a problem with the function of the cone photoreceptors, the photoreceptors that are responsible for sharp vision. And it's characterized by severely reduced visual acuity, photophobia, nystagmus, the involuntary eye movements, and complete impairment of color vision. So they only see in shades of gray and white. And their electrophysiological diagnosis is actually more challenging because their regular responses, the rod response and the mixed response, are more or less normal, But when you look at the response to a white light flicker, you see that it is severely reduced. And this indicates to us that the rod photoreceptors are actually functioning really well, but it is the cone photoreceptors that are not functioning. So as I mentioned, this is a very rare genetic disorder. However, there is one place on planet Earth where it's very, very common. And it's a very kind of peaceful island in the Pacific called the Pingalap Island, where a founder mutation on somebody in the island caused a very high incidence. 1 in every 10 residents of this island actually has achromatopsia. This island is very famous because the famous neurologist, Dr. Oliver Sacks, who wrote a lot of books about medicine. One of them was actually Awakenings, that later turned into a movie with Robin Williams and Robert De Niro, but that dealt with post-flu pandemic encephalitis and treatment with levodopa. Wrote a book about this condition as well, and he talked extensively about that island, and it's called The Island of the Colorblind. That is the book. And if you have time, I actually suggest that you read about how these people live and function. It's a very cruel twist of fate because they live in this amazing, beautiful Pacific island, but they actually likely see something like this, which is something which is completely blurred and in shades of gray and white. So as I said, these are very varied conditions and they're very uncommon, but within that uncommon family, there is a lot of variability, so I could not possibly cover it all. I brought you 2 interesting examples, and now I will turn it over to Morgan, who will talk about genetic testing, which is extremely important because this is what usually gives us the diagnosis and the information that we need to potentially treat the patient. Morgan?
Great. Thank you so much, Dr. Rosin, for that introduction to dystrophies as a whole, and thank you to the Foundation for having me today. Like Dr. Rosin mentioned, I'm going to get into some of the genetic testing surrounding IRDs. Okay, so first I want to just kind of share this image. There are upwards of 300 genes that are implicated in many of the IRDs, both those that are syndromic and non-syndromic, with many different inheritance patterns across all of these genes. The diagram depicts some of the genes that are involved and their associated clinical diagnosis. As you can see, there are many overlaps in these diagrams because these genes can cause multiple conditions depending on where the exact genetic change occurs. And this is really important to consider when thinking about what genetic tests to order or analyzing what genetic testing has already been performed in the past. Because of the overlap in genes and the similarities between symptoms of these dystrophies, we often recommend taking a panel-based approach to genetic testing as opposed to targeting just one single gene or doing a more broad scope testing. So this panel-based approach encompasses multiple diagnoses across lots of different symptoms, and again, is oftentimes our first line approach to genetic testing. While of course there are limitations to the panel-based approach, having an awareness of this, with your provider and helping to select the best test for your condition. Thinking a little bit more in depth about the panel-based approach that we have, these gene panels are curated sets of genes that are known to be associated with certain conditions or a collection of clinical symptoms. And the panels are limited to the genes that we know cause these specific conditions. There are many labs that have IRD panels, and no 2 panels at these labs are the same. The other thing to keep in mind with these gene panels is they are constantly changing. When we think about what panel we are selecting, what lab we're using to order genetic testing, the first thing that we think about is what genes are included on that panel. Some panels have several genes, whether it's 2, 3, 4, or 5. There are other panels for IRDs that have hundreds of genes included. These panels, again, are often updated over time. There are genes being both added and removed at any kind of given time. Most genetic testing reports that you receive from a lab will include the number of genes that were tested, along with a list of what those genes were. Another thing that we looked at when deciding which test to order is the testing technology. So the sequencing technology for genetic testing differs between labs. There can be some very tricky regions of genes to sequence. And then there are additional variants that are hard to sequence as well in certain genes. So it's really important to understand not only the genes that are being targeted on a specific panel, but also how they're being sequenced, and knowing that it's not the same between all of the labs. Another thing that we look at is the quality of the specific genetic testing report. Labs have different access to resources that they utilize when interpreting genetic testing results, and writing the reports that are ultimately shared with us as your care providers. Certain labs also have more experience with genetic testing for IRDs and genetic testing in ophthalmology in general. And having access to one of those labs oftentimes improves the quality of the report that we are able to obtain. The last thing that we consider when thinking about the genetic test we're ordering, the specific panel in the lab that we're going through, is the cost of genetic testing. Genetic testing can be very expensive, so we take that into consideration, as well as the financial assistance that may be available if there's a financial assistance plan through that specific lab, what those options are to make sure that we're making the best decision, and talking about the best options that are available in each situation. Thinking more about that and how to access genetic testing, there are three primary kind of methods on how patients are able to have genetic testing ordered. Those are insurance, self-pay, and the option for sponsored genetic testing. Thinking about insurance first, when someone's interested in genetic testing and wants to go through their insurance plan, we initiate a prior authorization process, providing the insurance company with clinical information, with family history information. We have pretty good success in getting authorization obtained for genetic testing. But it's important to note that just because testing is authorized does not mean that there's not a cost associated with that testing. Next option that we have is self-pay. Self-pay is exactly that, paying right to the lab for the cost of testing. Again, that can be different depending on what the panel is and what lab we're going through. The last option we have is sponsored testing. And we're lucky that we have two sponsored testing programs available in ophthalmology specifically for these inherited retinal diseases. The first one is the My Retina Tracker sponsored testing program through Prevention Genetics. That's sponsored by the Foundation Fighting Blindness. And the second one goes through a lab called Invitae. Its program is called Unlock Invitae Inherited Retinal Disease. There is different eligibility for both of these sponsored testing programs. There are certainly limitations and benefits to each, but both involve data sharing, and together helping to improve access to genetic testing. Thinking a little bit more about them individually, the My Retina Tracker or MRT program, to be eligible for that, you have to have a diagnosis of one of their IRDs listed in their website, as well as genetic testing. If you've had genetic testing in the past 3 years, it has to occur on a panel of 32 or fewer genes. If your genetic testing was performed more than 3 years ago and was negative or inconclusive, it's something that you may be eligible for. Invitae's program is similar in that they require individuals to have a diagnosis of an IRD or have a family member with a diagnosis of an IRD. Invitae, their sponsored testing program is dependent on the insurance coverage. If there's a clause in the insurance that states that genetic testing isn't covered, then Invitae and Unlock may be an option for those individuals. Regardless of the option or way that we pursue genetic testing, there are 3 different results that can come back. And when we get the results back, it's really important for us to interpret those results based on the clinical context that we have from the individual's history. All of the testing that Dr. Rosin spoke about is very important to have performed before we do genetic testing so we can better understand the results and really what they mean in relation to the other testing, all of the imaging that's been done. These 3 different results we have are positive, negative, and inconclusive. Thinking first about our positive results. A positive result means that we found an answer that we know is significant enough and fits with an individual's history to explain their condition. When we think broadly about testing for IRDs, we get a positive result up to kind of around 70% of the time when we do genetic testing. That means the other 30% were either with a negative or inconclusive result. Thinking about negative results, it means that we do testing and we don't find an answer. When we have a negative genetic testing result, we can't say conclusively that it is not a genetic condition. We can only say that based on the testing technology that we currently have and the genes that we looked at on that specific panel, we didn't find an answer. Last option is that results come back as inconclusive. That leaves us somewhere in the middle, meaning something was found when we did the genetic testing, but we're not sure yet if it's significant enough to cause disease. In the kind of times when we have these inconclusive results, sometimes we recommend doing testing on family members. There's more work required kind of on our end to come up with a better understanding of what that result means. So as you can imagine, the type of result really determines what the impact is for the patient and can help lead us towards what the next steps are in managing care. When we have a positive genetic testing result, again, that means that a genetic cause was identified, and it has various clinical utility and what that means for how we can care for patients that have one of these positive genetic testing results. That goes as far as to explain a diagnosis, give us a little bit of prognosis, talk about risk for relatives, systemic manifestations, as well as treatment options. First, being able to have a diagnosis. So a positive genetic testing result allows us to put a name on the condition that we may not have previously been able to do. It can also explain some of the previous symptoms that were otherwise unexplained. Can also give us information about prognosis. So genetic testing and having a positive answer isn't a crystal ball. It's not going to provide us with all of the information, but it can give us more of a roadmap, more information than we might have going into the testing. It can provide us with guidance and expectations onto what the path might look like moving forward, what some obstacles and barriers may be that go along with that diagnosis. It can also help us to determine how frequently we might recommend seeing an individual back in clinic and what type of testing is needed and what's useful. When we have a positive genetic testing result, we're also able to discuss the risk for relatives. Genetic information passes through families in a variety of different ways. If we get an answer back on testing, we can assess the risk for relatives, help organize testing for individuals that might also be eligible for testing through some of these sponsored programs, and help schedule them for appointments when appropriate. With the systemic manifestations, these IRDs can be isolated to just the retina and just the eye, or they can be syndromic, meaning they affect other parts of the body. Some systemic manifestations that we find and recommend proactive screening and management for involve cardiology, audiology, and some other specialties, depending on what the exact gene is. With systemic manifestations and these positive genetic testing results, it helps give us more information on symptoms that could be expected in the future and allows us to provide better surveillance for such symptoms. The last thing that these genetic testing results can help inform is treatment options. There are some targeted gene therapies available, whether it's an FDA-approved therapy or clinical trials, which Dr. Sahel will get into more information on. In some cases, there are also surgical implications for these genetic conditions that can be better guided by having one of those positive results. While genetic testing has many positive, aspects, there's a lot of good that can come from genetic testing. There's still a lot that we need to learn. It's certainly not a perfect thing. And these are just a few of the reasons why. First, not all IRD genes are known, and not all patients with an IRD will have a positive genetic testing result. We are limited by the knowledge that we have. So we apply what we know to this genetic testing, but there are certainly genes that are yet to be discovered. And with that information, as we learn more over time, our testing strategies will improve. We will have more options for patients going forward. It can be a long journey having a diagnosis of one of these IRDs to get to a point where there's a positive genetic testing result. The other thing to consider is that not all genes will have a targeted trial. So this, in the case that we do have a positive genetic testing result, it doesn't automatically mean that there's a specific trial available for that gene. Even if there is a trial available for that gene, it doesn't automatically mean that it's something that you would be eligible for. There are a lot of factors that go into being eligible for a gene therapy beyond just having a variant in that specific gene. As I mentioned, Dr. Sahel is going to get into more of the information on both targeted therapies and therapies that are available regardless of the result of genetic testing. Last thing is our future directions with genetic testing. So over time, we are getting better at understanding genetics in ophthalmology, genetics in these retinal dystrophies. So it's important to consider updated genetic testing over the time in scenarios where previous genetic testing results may have been negative or may have been inconclusive. As our knowledge continues to develop, there's more opportunities. Some of these things include the identification of new genes. So when we find new genes, it gives us new places to look for patients that were previously unable to find an answer. We also have advancements in our sequencing technology that improves our ability to detect the causes for these genetic diseases. We can identify new targets, and previously those regions that were tricky to sequence have the ability to do that. When we have these advancements in sequencing technology, we will go back and reanalyze genes that were previously looked at just to make sure that we didn't miss anything the first time. We also have the development of many new therapies that are coming into clinical trials. Some of those are gene specific. So in order to be eligible for those, we have to have a positive genetic testing result. And then the last thing is, with increased access to genetic testing for IRDs, with more sponsored testing options available, it's another reason to consider doing updated genetic testing, especially in the case of the My Retina Tracker program, where 3 or more years of testing may have passed, and there are new updates available. When considering doing updated genetic testing, it can be very helpful to sit down and talk with a genetic counselor. At UPMC, we are very lucky to have a team of 4 genetic counselors in ophthalmology, thanks to the excellent support we have from physicians both here at the Vision Institute and at Children's Hospital as well. So thank you for your time, and I'm going to pass along to Dr. Sahel to get into some of the treatments.
Thank you very much, Morgan and Boris and Heather. So I'm going to go quickly through some of the current advances we have in that field. And obviously, there is more that we can leave for questions and especially for the future. As a reminder, vision in humans is both central and peripheral vision. Central vision is very high acuity. This is where we read, we recognize the faces, but we are also relying on the peripheral vision for a lot of activities, alert activities. We also have a system in the retina that allows us to see in the dark and to see with strong lighting. And all of this is relying on the distribution of what we call photoreceptors, the cells that are capturing the light and triggering responses that Boris Rosin spoke about a moment ago. And in retinitis pigmentosa and other conditions, these photoreceptors are affected, very often the rods and then the cones. But there are also many conditions that affect the central retina. Dr. Rosin mentioned achromatopsia as an example, which is more distributed, but affecting the central retina predominantly. And there are many conditions, like, for example, Stargardt disease, that affect the central retina that we call macular dystrophies. So when we are dealing with a patient affected, we have to realize that there is a spectrum. There are around 300 genetic conditions of the retina. So, and I'm going to skip that slide because Dr. Rosin already described how the function is occurring in the retina. Just to remind you that in retinitis pigmentosa, the condition is affecting initially the peripheral retina and then the central retina. And in conditions affecting the central retina, like Stargardt disease, but also age-related macular degeneration, which is not the topic of today, it's mostly the central retina that is affected. And the visual defect is very different. You can see details, but nothing in the periphery in retinitis pigmentosa. And this is the opposite in macular dystrophies. The work I'm going to present is the work of many people. I don't have time to give the names, but I want to describe the continuum of the current therapeutic approaches that are being developed. The ideal therapy would be to correct the gene defect. So you heard from Morgan the numerous gene defects that are affecting the retina. And when you know about the gene defects, sometimes there are some attempts using gene therapy or pharmacology, but mostly gene therapy, to bring back the normal gene or to correct the mistake in the code, the genetic code that is leading to the disease. If you do it early enough and you are able to target as many cells as possible, it could be considered as a cure. There is only one example currently of a product that has been able to address that, not fully, but quite well, which is Luxturna for one form of the childhood blindness in what is called Leber congenital amaurosis. One of the genes, there are many genes in this disease, one of his genes, RPE65, has been targeted successfully, and there is now a product on the market, and the UPMC is a center for this therapy. But this is a very small number of patients, and most of the time, it's mostly restoring some visual function, but not all visual function. There are many genes that are currently subject to trials, and we are eagerly waiting for results. We are involved in many of these trials, not all of them, but many of these trials, and obviously hoping that some of them will turn out to be positive, but I will mention the challenges in a short moment. Then there is one stage of the disease where it's probably too late to rescue the photoreceptors because they are already advanced in terms of degeneration, or because many of them, especially the rods, have degenerated. And this is a work I've been conducting for many years, and others have been working on that to protect the remaining cells. It's called neuroprotection using trophic factors, for example. We have an ongoing trial. I will mention that briefly. And then there is a stage of a disease where you cannot really hope to maintain useful vision. So you have to try to restore some useful vision. And this is where prosthetic vision, cell therapy, and optogenetics have been tried. And we have been involved in many of these efforts, and I will mention that briefly also. We have many challenges. The main one is to make sure that we don't do anything dangerous. This is always something we have to weigh in, and everyone considering any therapeutic approach in a condition like that should remember that this is very complex, that the retina is very fragile. And of course, everyone wants to get a treatment, but you should not put yourself at risk. So ask a lot about the risk and the benefit. The stage of a condition, as I mentioned a moment ago, is going to really be a key decision-making in what type of trial could be relevant. Depending on the stage, you could be curative if you are early enough, or you could be palliative, which means that you might be able to protect some remaining vision, but not more than that. And this is when especially you target common pathways in the course of the disease. The challenges we are currently facing is, are we willing to demonstrate an improvement or just maintenance? So is this just protection or is this restoration? How do you demonstrate the activity, the efficiency? And especially, is the efficiency going to be useful in daily life for the patient, or is this going to be nice for us to see a positive result on a test, but is this going to have any impact on the life of our patients? We start with gene therapy. Gene therapy is trying to address the gene defect, and there have been some successes I did mention, but we are facing multiple issues that actually Morgan mentioned a moment ago. The number of mutations, the fact there are still a number of mutations that are unknown, the timing of intervention, as I described a moment ago, and clearly, how do we demonstrate the benefit? So I won't get into too much details because we actually had webinars already on these approaches, especially Luxturna, but I will focus on what happens later on in the course of the disease. And what we have to remember is that our patients initially are losing in retinitis pigmentosa their peripheral and dark adapted vision. And the dark adapted vision loss is the consequence of a mutation affecting rod photoreceptors. So patients are not able to see in the dark, and then they lose some peripheral vision. And they have what we call a tunnel vision, where we can see in the middle pretty well. And then over time, this tunnel becomes more and more narrow, and eventually it could lead to a more severe loss of vision. So when we talk about defining a therapy that could help the patients, we are trying actually to address one of the key requests that is posed in front of us. Can you protect what I have left? And we have been working on that for many, many years, looking at what happens in the course of the disease. In the course of the disease, this is an image from Web Vision about the evolution of the disease. Photoreceptors are the first cells to degenerate, and then there is what we call remodeling in the rest of the retina, and especially the cone photoreceptors, the cells that are enabling central vision and color vision, are degenerating over time. So we try to target that, and for that we thought that it would be very important to protect the cone photoreceptors. There is strong evidence from scientific work that even if you protect only 50% of a cone, you could maintain normal visual acuity. Doesn't mean normal vision, but normal visual acuity. And even a small number of cones, only 5%, could enable the patient to retain orientation, discrimination, performance. So the goal is really to transform the disease from a progressive disease where patients are losing sequentially peripheral vision, central vision, into something that would be more stable and manageable in daily life. So we worked a lot, and I'm not going to be entering into too many details, but my team back in Paris and now in Pittsburgh has been working on trying to understand why the cells that are not affected primarily by the gene defect, the cones, are degenerating. And we identified that there is a signal that is made in the normal retina but when the rods are still alive, and that this is maintaining the cones alive through different mechanisms. This led us to design a therapy whereby we try to restore the signaling, to bring back the signal that was lost, that my group has identified. And this was commented by a colleague of us some time ago. And the goal in the treatment is to restore the part of photoreceptors that respond to light and to protect that. So after many, many years of work on that by my group, this led to a clinical trial, which is ongoing, both in Paris and Pittsburgh and a few other places now across the world. And we are in the middle stage of this trial. And at this stage, it is safe and hopefully it's going to be promising. The other stage of the disease is when the patients are no longer able to protect remaining vision because they lost most of their vision. And we identified a stage of the disease where the cone photoreceptors have already undergone a significant degeneration, but are still alive. And we call that dormant cones. This is what you see in this retina, which is coming from a post-mortem analysis of the retina in a patient with advanced disease who still has remaining photoreceptors. And what we are trying to do in an approach that we call optogenetics is to reactivate the remaining cells. This is using a very peculiar mechanism that exists in very rudimentary organisms like algae and microorganisms where they are able to detect the light and able to move away or towards the light because they express a protein that is both responding to light and triggering an electrical response. This is a very rudimentary mechanism that you see on the right-hand side of the slide. And we thought that it might be useful in patients where all the machinery that is responsible for responding to light is broken in retinitis pigmentosa, to replace this machinery with this single protein. So we developed a gene therapy approach to do that. And we tested that on multiple cell types in the retina. And I won't get into too many details, but what I'm going to show is what we did in very advanced stages of a disease in the ganglion cells, the cells that are connecting the eye to the brain. These cells normally don't respond to light, but even in advanced stages of a disease, this is an imaging we use in the clinic that Dr. Rosin mentioned, optical coherence tomography, where we image the retina like in sections. We don't section the retina. You see, it's a non-invasive technique, but we see the ganglion cells. They are painted in orange, and you see that at every stage of the disease, they are still alive. So the idea was to express these proteins that are responsive to light in the remaining ganglion cells to provide some function, to some response to light. So we did that, and we did a lot of preclinical work to find what protein to use, what vectors to use in gene therapy. We modeled that in different models, and we showed that there is a signature in the retina for every single shape, and we could predict the type of visual acuity could be obtained using artificial intelligence. So based on all of this work, which is 10 years of work on one slide, we started a clinical trial where we were able actually to treat the retina by administering a gene therapy vector to express a protein sensitive to light in the remaining ganglion cells, the rest of the retina being damaged by the disease, to activate that using specific goggles. So what we used is really a combination of the vector being injected into the eye to target the cells and goggles that are stimulating the retina and have cameras that are capturing the information and sending the information to the retina. And after we started the trial, the first patient in Paris and now several others reported that they were able, although they had been totally blind before the trial, to see some shapes, to see some objects, to count the objects, and using recording at the level of the brain, or using the equivalent of electroencephalography high resolution, we were able to record the activity in the brain and to show that it corresponds. So this is a patient, for example, who was totally blind and is now was able to count how many pens are on the table. You can hear her, but this is what she's saying. And then she's able to see also the edge of the table. And she does that slowly, obviously, but as compared to nothing before, it's much better for her. And what you see on the screen is what she can see. And she, as you can see, she can point towards one of the pens. So quite successful. And this is another patient in the study. And we could show that you could activate the brain in this patient. So now there are many groups that are working on the same approach. Our group was done in partnership with GenSci Biologics. There are others that started but have disappeared, like the Allergan, the Retrosense, Vedere, and others, but there are still some that are developing products, and we are currently doing a trial with Ray Therapeutics, and we are planning to implement a new technology to increase the resolution. I don't have time to get into that, but this is a big effort currently in our department in Pittsburgh to increase the specificity, improve the resolution of the images, and get to the next generation of optogenetics. There is another approach, which is artificial retina. I've been involved in many of these trials over the years. Initially, we were using implants to stimulate the innermost cells in the retina, the ganglion cells. And we got successful results with that, but not very high resolution. And we developed another implant together with Daniel Palanker at Stanford, who originated the technology, where in the retina where there is no photoreceptor, we implant actually a chip with photodiodes that is responding to light. And then this is being stimulated from the outside using a projector, like I showed for optogenetics. So these are goggles that are sending the information onto the eye. And this is stimulating the chip. And this information is being sent to the brain. So I'm going to expedite that for the sake of time. We have done 3 clinical trials in Europe and in the US, including Pittsburgh. And we showed that there was an improvement of vision that was quite significant and impressive. And we showed also that patients could retain their peripheral vision. It was done in patients with central macular involvement in age-related macular degeneration. And we just completed a multi-center trial in Europe with 38 patients involved. And this is the improvement of visual acuity, more than 15 letters in the majority of the patients. So seeking approval in Europe to propose that to patients. I'm going to skip the last part because we already had a webinar on the street lab and the ability to test vision in patients. We developed a lot of tools to document the ability to restore useful vision in our patients. But I just want to conclude by saying that we are trying to develop approaches that are meaningful for the patient, that are going to make a difference in their daily lives. But we are really on a very long roadmap. It's not going to be an easy roadmap. This is a lot of work with a lot of people. You are seeing a few on the screen today, but there are many more. And we benefit from the support of the INDR Foundation for that, from many donors, some of them online today, and from Foundation Fighting Blindness, the NIH, and other institutions, because a lot is needed to help some of our patients to get back some of their vision, or to regain or to retain some of their vision. Thank you very much.
Thank you. That was a great webinar, and we have quite a few questions to begin. If for some reason we don't get to your question today, we will email you with an answer. So let me start. Can anybody get scheduled to have genetic testing done?
Morgan?
Yeah, I'm happy to address that one. We are certainly happy to see patients for genetic testing. In order to have genetic testing done here at our center, patients have to be established with one of our dystrophy physicians. So whether it's Dr. Rosin or Dr. Sahel, the first step is coming to see us in clinic. So I'm happy to help anyone get scheduled with us in clinic, but it's important to have that visit first so we can do all of that in-depth testing in order to better interpret the results of testing.
That's great.
And the clinic we have is also involving a low vision team with Dr. Smith and his team in low vision. So we have a very integrated clinic where we try to do all the testing, the genetic testing, the genetic guidance, and also the support for low vision for our patients.
Thank you. Now, this is a very interesting one. How common geographically is this type of genetic testing? I know people come from far away to be treated in the clinic, but how common is it to be able to get this genetic testing done?
Morgan?
Morgan?
So both of our sponsored genetic testing programs are available throughout the country. It's not just kind of here in Pittsburgh or even in Pennsylvania. Throughout the country, worldwide genetic testing is available. It depends on the exact hospital system that you are working with and what access is available. Things like insurance certainly play a part as well. But it's, throughout the country, we, like I mentioned, are lucky here to have 4 genetic counselors. Most sites do not have that. So we're grateful for the support we have in order to help patients get access to genetic testing.
All right, so I'm going to ask a question. How did you decide to be a genetic counselor?
I decided to kind of get into genetic counseling many years ago, back before I started in undergrad. But I think genetics is a fascinating field. And I think the integration with ophthalmology and the development, all of these gene therapies really gives patients something to look forward to. And I think that's part of why, I've decided to get into this field and stay here and be part of this team.
And I think it's important for people to know, we always think about, oh, I'll become a doctor, I'll do this. But, genetic counseling is another really neat science, medical, healthcare job. Yeah.
Yeah. We, enjoy our time and the experience that we can lend to patients.
Is retinitis pigmentosa always hereditary, or are there environmental factors that can cause it as well?
Retinitis pigmentosa, per definition, is an inherited retinal dystrophy. So there is a genetic defect. However, There are conditions, certain infections or inflammations that can mimic retinitis pigmentosa, and they have the appearance of retinitis pigmentosa, but there is no underlying genetic defect. Usually very difficult to distinguish, but these things exist.
So it mimics it, but it's not it.
Correct.
Gotcha. Is genetic testing available for other conditions? You know, that's something that's talked about quite a bit, especially at McGee Women's Hospital, but I'd love to hear Morgan and both Dr. Sahel and Dr. Rosin offer their thoughts on this.
Morgan?
Certainly, there's genetic testing for all different types of conditions. You know, especially in ophthalmology today, we focused on retinal dystrophies, but there's lots of other types of genetic testing just focused, you know, in the eye. Outside of that, head to toe, lots of different genetic counselors in all different types of specialties. So, you know, any interest in genetic counseling for any of those conditions, it's certainly something that we can help connect to.
Thank you. What is the average length of time to get genetic testing results back?
That is another excellent question. And that really depends on the lab that we're using, the size of the panel that we're doing. Sometimes we can get genetic testing results back in, you know, 4 weeks. Sometimes it may take up to 3 to 4 months. It just depends, you know, on the specific instance, the specific case that we're talking about.
Thank you. Is the advancement of AI playing a role in genetic counseling at all? Morgan's popular today.
You know, that is something that is being discussed right now in the field. It hasn't impacted our counseling directly here yet, but I think that as AI continues to evolve, it's very possible that it will play a bigger role in the future.
I can speak a bit to that. So we are starting. So we have a lot of AI in the department, mostly quantitative AI and advising on progression of disease in aging. But we have also started a collaboration with a group in London that has actually developed algorithms where, based on the presentation of a disease, they are trying to correlate with genetic background to try to predict what gene is most likely to be involved. We have this type of approach in the clinic, but it's most based on our experience, how many patients we have seen. So it's trying to make it available to people that don't see patients all the time with these conditions, and actually even for us. So this sounds very promising. It may help actually in focusing the genetic testing in depth on a few specific genes for especially very complex conditions. So this is coming. It won't replace any of us very soon, but it will help.
Thank you. And our last question, do you have animal models for IRDs?
So many, I'll hand off to Dr. Rosin, because this is one of his favorite questions.
Yes, excellent question. Yes, so there are many animal models, and back in the day, I would say up to 5 years ago, we were mainly limited to animal models that occur naturally, meaning that there is a founder mutation in some sort of an animal that kind of progresses and it results in a large cohort of animals that have these diseases. For instance, in rats, there is a very famous story about rats being found in the Royal College of Surgeons in London, which is a medical school, in the dungeon, that behaved very weirdly, and they only saw well during the day and not so much at night, and didn't really rely on their vision. And they have retinitis pigmentosa, with the mutation that is actually a mutation that causes retinitis pigmentosa in humans. There is a cohort of sheep in the state of Israel in the north that behaved exactly the opposite, and the sheep have a mutation that actually causes achromatopsia. And there is a very famous herd of dogs, or like a group of dogs, that actually have a Leber's congenital amaurosis. And on these dogs, the first trials that led to the FDA approval of Luxturna, which is the only approved gene therapy for an inherited retinal dystrophy, was actually performed. Since, well, over the past, I would say, decade, gene editing is something that kind of like took hold. And nowadays, there are a lot of models that are created using technologies that allow us to introduce mutations into animals in utero and develop models of essentially any inherited retinal disease that we would like. And there are many examples of many, many exciting studies that were done, and that, in essence, kind of cancels out that limitation that we had before of being kind of confined to having a model that occurs naturally. Now this is no longer the case, and it opens a huge avenue of research that was not available before.
Thank you, Dr. Rosin, and thank you, Dr. Sahel, Dr. Rosin, and Morgan for a wonderful webinar today. It was great. We had a large crowd. And to our attendees, join us in 2 weeks for another Sight and Sound Bite webinar with the Department of Otolaryngology. Thank you all. Have a good day.